Anyways, thanks to the organizers. I know we're 15 minutes behind already or something like that. So I'll try and get us caught up, speaking relatively quickly. So John asked me to talk about some work that a company I co-founded and continue to be involved with has been working on. So I'll give you some updates on that. So let's see. So my disclosure I just gave, founder and I advise the company in terms of medical affairs. The company is called ImagineApp, based in Los Angeles, and one other disclosure there. So what I'm going to talk about is imaging. So we're going to come back to a little bit of the topic that Oliver introduced earlier today, which is really, what we define is based on what we see. So oligometastatic disease, how do we define it? Right now, it's based on the kind of imaging that we have. So we don't truly understand it. So the idea of using antibodies for imaging is not new. And the idea is quite simple, which is that it's a way to do immunohistochemistry in vivo. Since biopsying every possible lesion on a patient with metastatic disease is obviously something we cannot do, the idea is if we can actually do that type of assay in vivo, we may get a better picture of disease. And so, and then we all know about the properties of antibodies that make them exquisitely good agents to target any given cell surface protein. And so these can then be optimized for imaging. So one of the great properties about antibodies for therapy is that they have a very long half-life. So you can dose them once every week or once every 2 weeks, and they accumulate and stay in a tumor. But that makes them actually very poor for imaging, where you want to get a quick readout, and you need high contrast. So you need a high signal to background or high signal to noise ratio to get good contrast and good imaging. So my colleague, Anna Wu, who I've been collaborating with and working with now for almost 15 years, when she was at City of Hope, developed the idea of essentially re-engineering antibodies to make them better for imaging. And she actually developed these with the idea of doing radioimmunotherapy, which is an idea that I think is now starting to come back again. And I've talked a lot with Oliver about that concept as well. But anyway, so you can re-engineer this antibody, which usually if you use it for imaging, you have to wait about 5-7 days until you get enough clearance from blood and normal tissues to get high contrast imaging, as shown on the left. And this is actually an antibody that we developed against prostate stem cell antigen, PSCA. One of the targets, I'm not going to have much of a chance to talk about it today, but one that we've been working on for a long time. You can re-engineer that into a smaller fragment called a minibody, which has, of course, much smaller size. It's about 80 kilodaltons and therefore clears much more rapidly from systemic sites such as blood. And you can get a high contrast image at a much shorter time point, basically within 1 day as opposed to 1 week. And then you could further engineer this into a dye body, which is essentially 2 single chain scFv fragments combined together through chemistry, and you can actually get something that even clears more rapidly. And actually, we have a publication just came out yesterday. Somebody mentioned that they saw it using a PSCA dye body for fluorescent optical imaging for in vivo surgical imaging that just came out in Clinical Cancer Research. If you want to see some more work related to dye body. So as I mentioned, this is a great platform essentially for imaging any cell surface target. And this is work from Anna Wu's lab, my lab, other collaborators, as well as ImagineApp, essentially showing that you can use a platform technology against either using a dye body or mini body platform and image essentially any cell surface protein. So HER2, PSCA, PSMA, which is what I'm going to talk about the next few minutes, CD20, et cetera, et cetera. So it's a really elegant platform technology to be able to image anything that you want. For instance, we've been working on imaging PD-L1 because we think that, at least in some tumor types, as you've heard, levels of expression may correlate with response to PD-1 or PD-L1 inhibition. So rather than doing biopsies to assess it, I think we would learn much more if we could actually assess it globally in tumors in metastases. So now back to prostate cancer, which is why we're here. There are many different unmet needs for imaging in prostate cancer. I'm going to talk later today about imaging early stage disease. So I'm going to actually focus a little bit on imaging later stage disease, imaging metastases in lymph nodes, bone, et cetera, et cetera. There we also have very poor imaging agents. Right now we have bone scans, traditional bone scans, which image bone, but not tumor. We've got other isotopes such as choline and acetate that are actually pretty good, but still somewhat dirty because they're not specific for cancer. And then, as you've heard, we've got a series of different PSMA and other prostate cancer targeted agents coming about. So what the company did is it collaborated with Neil Bander's group at Cornell, who developed the J591 antibody that's been in the clinic for a long time. Many people know about. And the idea was very simple: re-engineer this to make it a better imaging agent that could be used for both imaging, but potentially other applications as well. Because one of the other nice things about this platform is you have the opportunity to conjugate essentially any moiety that you want. So you can conjugate a fluorescent probe to it, a PET probe, a radioisotope, a drug, a toxin, et cetera, et cetera. And so this has now gone from the lab at the company to the clinic. And I'm just going to show a few slides to give you some update on where we are in terms of development of this tracer. So this is from the phase 1 study that's been done at Memorial Sloan Kettering by Mike Morris and Nita, and I'm spacing on her last name. She's not here, but I apologize. And this is a phase 1 study, and the purpose of this essentially was to compare imaging with this tracer to standard of care imaging, at least in the United States right now, with either FDG, which is used actually fairly well in metastatic prostate cancer, even though the dogma has been that FDG doesn't work in prostate cancer, does not work in early prostate cancer. But as the group at Memorial has really demonstrated, and you've seen a few other images here, it can be used to image metastatic prostate cancer, and then bone scan on the left. So this is actually a pretty typical patient with metastatic disease, PSA 40, Gleason 9, and you can see on the left he's got multiple bone lesions that are easily visualized. On FDG, you actually see more lesions because you're seeing soft tissue in addition to bone lesions. And then with the PSMA PET probe, you can see not only many more lesions, but you can also see much higher contrast, much brighter signal. And this is very typical of what we see. And this imaging is done between 24 and 48 hours after administration of the tracer. And then here's another case where you can see with the PSMA probe, you can see these lesions in bone on the top. I'm not sure where the pointer is. Maybe it's here actually. There it is. So you can see you can image this lesion in bone quite nicely. You really don't see much on CT scan. And then actually the team at Memorial used this to conduct their stand-up to cancer biopsies. So we biopsied many of these sites, and we're able to show with, I think, about 95% sensitivity and 95% specificity, more or less. I didn't bring the numbers for this very short talk. So showing that PSMA positive lesions are prostate cancer. And so you can see both bone lesions, but you can also see soft tissue lesions very nicely down here. And you can detect lesions as small as a few millimeters. So this appears to be a very sensitive and specific tracer for prostate cancer. And I think an important point is what the radiologists talk about as being discordance. How many lesions are picked up differentially between different techniques? And in the case of this phase 1 study and phase 2, 65 unique lesions were seen in bone with this tracer in about 12 patients, and 32 soft tissue sites were actually found that were not visualized with standard of care technologies. And overall, about 30% more lesions were detected with PSMA tracers than with conventional imaging. Again, suggesting that we really are under-detecting and underappreciating the extent of disease with prostate cancer, even patients with widely metastatic disease, and that better imaging can detect them, therefore be better, more useful for detecting metastases in patients with high-risk cancer, time of biochemical recurrence, and for monitoring patient responses after given therapeutics. And later in my next talk, I'll show you some of the data from a high-risk trial that we've been doing, which is interesting. This is just one patient from that high-risk trial. So these were men with high-risk prostate cancer prior to surgery. They were then imaged. The standard of care in the United States is still Prostacint, even though almost nobody uses it, which is a PSMA antibody. And so we compared, or they compared, Prostacint against this PSMA IAB2M minibody tracer, as well as CT and standard of care imaging. And for instance, here's a guy with high-risk prostate cancer. He basically had absolutely nothing detected by MRI and nothing detected by prostatint, but he actually had this lymph node, normal-sized lymph node, lighting up, and this was confirmed to be cancer at the time of a radical prostatectomy. And I'll show you some of the data from that trial, which is still ongoing, so it's still early data and it's still being analyzed. I think the important point is that, as you can imagine, prostate cancers and lymph nodes, you may have a centimeter lymph node, but the cancer itself may only occupy 1 millimeter or less of that lymph node. And so we have some early measurements suggesting that we can detect that this tracer can detect as little as 1 millimeter of cancer within an involved lymph node. And so I'm going to go over this later for the sake of time in terms of what we found in the first few patients. So the next thing, just for the last couple of minutes, I'm going to talk about is kind of where the company and our collaborators in academics have been moving beyond imaging the tumor itself. We've heard a lot about immunotherapy, immunology in multiple GU cancers. And so the idea of imaging the immune system makes a lot of sense because whether it's vaccines, PD-1 inhibitors, or potentially even engineered T cells, knowing who's going to respond, knowing if they're responding, knowing where off-target toxicity with T cells may be is potentially very important. And so what's been done both academically and now in the company is to develop minibodies and diabodies that can image CD8 and CD4. I'm going to just show you a couple slides of CD8. Tony Ribas, one of the collaborators on this project at UCLA, said CD8 is the drug. The T cell is the drug for immunotherapy, so why not image the drug? And so this is some preclinical work that Anna Wu's lab has been doing together with Tony Ribas's lab. This is using not a minibody, but a cis diabody, again, engineered to be a PET probe with zirconium-89, CD8-specific mini diabody. And so a couple of studies have been done to confirm that this can actually image T cells in real time. So the first set of experiments were done actually in a stem cell reconstitution model. And so here, what you can see in this is after reconstitution. What you can see is the spleen is now completely occupied by T cells. And I'm not sure if you can see it on the edge here. I promise you that's the spleen. The diabody gets excreted through the kidney, so you're seeing the kidney background here. But the spleen now takes up contrast, takes up the tracer, and if you block it with a neutralizing antibody to show the specificity, that can abrogate the signal that you get. And then you can actually look in a time course in terms of post-hepatic hematopoietic stem cell transplantation. And what you could see is that at 2 weeks, you're starting to see a little bit of signal from the T cells in the spleen. But as time goes on and you see repopulation of the immune system, you see repopulation of lymph nodes as well as the spleen. And this is maintained over time. So this just demonstrates that you can actually very elegantly image T cells in vivo and that the imaging is specific for these T cells. And then in one therapy model that was done again by Anna's lab together with Tony's lab, this is a CT26 syngeneic tumor system treated with an anti-CD137 immunotherapy and in which the tumors respond. And I'll just show here on the left. So this is actually the tumor prior to treatment imaged with this diabody. And you can see that there are actually T cells pre-existing within the tumor, although the tumor continues to grow. But after administering the CD137 antibody, you can see now a very strong signal within the tumor. And this correlates very strongly with the presence of T cells in that tumor after therapy administration. And then you can block that with a diabody, demonstrating that this is actually specific for T cells within the tumor itself. So just a demonstration that you can image T cells both before and after therapy. And so now this will be entering different clinical trials really to ask the question whether you can image the baseline T cell infiltration in tumors, because there's significant data up there that may be predictive of patients who are likely to respond to checkpoint inhibitors, and then image them after therapy at varying time points to assess engagement of T cells and infiltration of therapeutic T cells essentially in the tumor itself. thinking that this may be both a good prognostic and predictive marker for T-cell therapy. So I'm going to acknowledge people in the academic labs, my lab and Anna's lab, who have worked on this, Tony Rivas I mentioned, and then the group at Imaginab, the clinical investigators at Memorial, Nina Panditaskar, now I'm remembering, and Mike Morris and Jason Lewis, who developed much of the zirconium technology that has then been adopted, and a collaborator at City of Hope. Thanks. So we have time for a few questions, I guess.
Pretty fascinating, Rob. Yeah, you know, one of the things that had sort of direct implications with rating, I was looking carefully at that PSMA scan. You know, usually the CT scan sclerotic lesions are where the cancer is. And actually, I was trying to see the sclerosis where the PSMA scan was positive. I couldn't see it. And, you know, maybe it was there, but it just didn't appear. So it was probably an infiltrative, non-osteoblastic type lesion. Would have missed that on bone scan and not treated it with radium.
Yeah, I don't know if that's been looked at extensively, but there's no doubt if you look at bone scans, there were cases where bone scan was positive, the IAB2M scan was negative, and the biopsy was negative. And then there were certainly many cases where there were simply many more bone lesions seen with PSMA targeted imaging. But that said, I also have to caution that not all tumors are PSMA positive, and there are a few cases, particularly in very end-stage disease, that don't image and turn out to be PSMA negative. Maybe they're neuroendocrine anaplastic, don't know, but there are certainly a few cases where even our conventional prostate targets may not be sufficient.
Yeah. Oh.
In a follow-up, though, in other cancers where PSMA is in the endothelium,
sure.
Have you seen it in glioblastomas, kidney tumors?
We have one imaging study ongoing in Japan right now in glioblastoma, so we'll find out.